Hello everyone. So today we are going to start our topic in obstetrics, that is about puerperal sepsis, and it is one of the abnormality in the puerperum. So what is puerperal sepsis? It is an infection of genital tract which occurs as a complication of a delivery, and puerperal pyrexia is considered to be due to genital tract infection unless proven otherwise. This is one of the dictum. And and what is puerperal pyrexia? And as we have already discussed in puerperal pyrexia in previous video, so again let's revise it once again. The puerperal pyrexia is a rise of temperature more than 100.4 degree Fahrenheit, more than or equal to 100.4 degree Fahrenheit or 38 degrees Celsius, uh, on two separate occasions, 24 hours apart within 10 days, excluding the first 24 hours following delivery. And nowadays there has been marked decline in puerperal sepsis during the past few years due to improved obstetric care and availability of wide range of antibiotic. The puerperal sepsis is commonly due to the endometritis, endomyometitis, and endoparametitis, or a combination of all these. When it is called as pelvic cellulitis. So these are all. It is commonly due to this condition. And talking about causes of other causes of puerperal pyrexia, this is puerperal pyrexia other causes. One, we have the most important cause, that is puerperal sepsis due to genital tract infection. Then we have the urinary tract infection, cystitis, pyelonephritis. Then we have the mastitis and the breast abscess, the wound infection, episiotomy, pulmonary infection or atelectasis pneumonia. Next, we have the septic pelvic thrombophlebitis and recrudescence of malaria or pulmonary tuberculosis. And other, we have pharyngitis and gastroenteritis. And these are the other causes of puerperal pyrexia. Now we will see how all this condition occurs. The puerperal sepsis is commonly due to this condition like endometritis, endomyometitis, endoparametitis, and pelvic cellulitis. And the vaginal flora is in late pregnancy and at the onset of labor consists of various organisms like duodenal bacilli, majorly Candida, Staphylococcus albus, or aureus, Streptococcus anaerobic. Anaerobic is common, and beta hemolytic, that is rare, and Escherichia coli and Bacteroides group, and Clostridium welchii sometimes. And these organism remains dormant. And they are harmless during normal delivery. Under a aseptic condition. And the various predisposing factors for puerperal sepsis are the pathogenesis of vaginal flora may be influenced by various other factors like the cervico-vaginal mucous membrane is damaged even in normal delivery. The uterine surface, the placental site, is covered into an open wound by the cleavage of decidua, which takes place during third stage of labor. And the blood clot present at the placental site are excellent media for the growth of bacteria. So we have the various antepartum risk factor for the puerperal sepsis. One is we have the anemia, and secondly we have the preterm labor. Next is premature rupture of membrane, and we have the prolonged rupture of membrane more than or equal to 18 hours. We have diabetes, and we have the immunocompromised, that is the condition like HIV. These are the antepartum risk factor for the puerperal sepsis. And we have the intrapartum risk factor. The repeat one is the repeat vaginal examination in intrapartum period. That is one of the risk factor. And we have we have traumatic vaginal delivery. Next we have hemorrhage, either antepartum hemorrhage or postpartum hemorrhage. And we have other thing like retained bits of placental tissue or membrane. That is another intrapartum risk factor. We have prolonged labor, obstructed labor, cesarean delivery, dehydration, and ketoacidosis during labor. So these are the intrapartum risk factor. Repeat vaginal examination, traumatic vaginal delivery, hemorrhage, antepartum or postpartum hemorrhage, retained bit of placental tissue, prolonged labor, obstructed labor, cesarean delivery, dehydration, and ketoacidosis. And we have due to various factor, due to this factor, the organism gain the foothold either in the traumatized tissue or the urogenital canal, or in the raw decidua left behind, or in the blood clot, especially in the placental site. The mode of infection, the puerperal sepsis is essentially a wound infection. The puerperal sepsis is essentially a wound infection. The placental site being a raw surface, laceration of the genital tract, or the cesarean section wound may be infected in the following way. The one is the source of infection. The source of infection might be endogenous. The endogenous, where the organism are present in the genital tract before delivery. The anaerobic streptococci. The anaerobic streptococcus is a predominant pathogen, and the autogenous, where the organism present elsewhere. This is in the genital. The organism present in the genital tract, and the anaerobic streptococcus. And autogenous, where other organism present elsewhere, that is skin, throat, in the body, migrate to the genital tract, genital organ by the bloodstream or by patient herself, and that includes the beta hemolytic streptococci and E. coli and staph. And these are also the endogenous cause. And next is exogenous, where the infection is contracted from sources outside the patient, from hospital or attendants. And next with that we have beta hemolytic streptococcus, staphylococcus and Escherichia coli. The pathology. The primary site of infection are perineum, vagina, cervix, and uterus. The infection is either localized to the site or spread to the distant site. The laceration on the perineum, vagina, and the cervix are often infected by the organism due to presence of blood clot or dead space. The wound becomes red, swollen, and there is associated seropurulent discharge, and there may be disruption of the wound if impaired before control of infection. The obesity, diabetes, immunocompromised state, HIV are other high risk factor for wound infection. In the pathogenesis, the endometrium, that is the placental implantation site, cervical lacerated wound, vaginal wound, that is episiotomy, or perineal lacerated wound are favorable site for bacterial growth and multiplication. The devitalized tissue, blood clot, foreign body, the retained cotton swab, and surgical trauma favor polymicrobial growth, the proliferation, and spread of infection. This ultimately leads to metritis, parametritis, and cellulitis. And talking about spread of infection, the pelvic cellulitis, parametritis, is due to spread of infection to the pelvic cellular tissue by direct or by lymphatic or hematogenous route. The infection causes exudation and formation of indurated mass, usually confined to the side of the uterus, at the side, and that is in the uterus. In that case, is pushed to the contralateral side. And the one next is we have the peritonitis, is common due to common following infection, metritis after cesarean delivery, and there may be necrosis of uterine incision wound and dehiscence, and patient present with the bowel distension and dynamic ileus, bowel distension and ileus. There can be salpingitis. It may be interstitial or parasalpingitis. Endosalpingitis is uncommon. And pelvic abscess. Following the pelvic peritonitis may be due to the spread of infection. Rarely there may be generalized peritonitis. With a dynamic ileus, pelvic abscess has become rare with the use of antibiotic. And a suppurative wound infection takes 7 to 10 days to develop. And the septic pelvic thrombophlebitis may involve the ovarian vein, uterine vein, pelvic vein, and rarely the inferior vena cava. The formation of thrombus in the deep pelvic vein are due to result of hypercoagulable state in the pregnancy. Once infected, these release septic microemboli that affect lungs or kidney. An imaging study can diagnose larger thrombus, and it is that. And next is we have there can be septicemia and septic shock due to hemolytic streptococci, streptococcal toxic syndrome, anaerobic streptococci, and septicemia may cause lung abscess, meningitis, pericarditis, endocarditis, or even the multi-organ failure, and death occur in 30% of the cases if the infection is spread. So what happens is that if the infection is spread from the genital tract, that may lead to the pelvic cellulitis, peritonitis, salpingitis, pelvic abscess, septic pelvic thrombophlebitis, and the septicemia and septic shock. And the clinical features are local infection, uterine infection, mild or severe, and spreading infection. As we have already said, the local infection, wound infection, there is rise in temperature, generalized malaise, or there may be headache. The wound becomes wound is red and swollen. The pus may form, which lead to disruption of wound, and with severe or acute there is high rise of temperature with chills and rigor. And in the uterine infection it has two types, mild and severe. In the mild infection there is rise in temperature greater than 100.4 degree Fahrenheit, and the pulse rate is even greater than 90 beat per minute. Pulse rate is very high, and there may be local discharge is offensive. Local discharge offensive, copious, and the uterus is subinvoluted and tender. Subinvoluted and tender uterus. In the severe uterine infection, the onset is acute with fever and with chills and rigor, and the pulse rate is rapid, out of proportion. Pulse rate is out of proportion with temperature, and often there is breathlessness, cough, abdominal pain, dysuria, and the lochia may be scanty and odorless. Uterus may be subinvoluted, tender, softer. There may be associated wound infection like in the perineum, episiotomy wound, or the cervix. And in the spreading infection, the extrauterine spread is evident by the presence of pelvic tenderness. In the spreading infection, there is pelvic tenderness, the pelvic due to the pelvic peritonitis. Sorry for my handwriting. And the pelvic cellulitis with tenderness on the fornix. There can be pelvic cellulitis with tenderness on the fornix due to parametritis. Bulging fluctuant mass may be seen in the pouch of Douglas, that is due to pelvic abscess, and the rare presentation may be like abdominal tenderness. So let's not remember rare thing. And there can be like spreading infection can cause rarely the parametrial phlegmon. This is also very rare. And one is toxic shock syndrome is this is due to Staphylococcus aureus exotoxin, and it is manifested by fever, headache, nausea, vomiting, diarrhea, and erythematous skin rashes. And major organ dysfunction like cellular renal failure, hepatic dysfunction have been observed. And the next there can be septicemia. In septicemia, there is high rise in temperature, usually associated with rigor. Pulse rate is rapid even after temperature settles down to normal. The blood culture is positive, and the signs and symptoms of metastatic infection to lungs, meninges, or joint may appear. And the bacteremia endotoxic or septic shock is due to release of bacterial endotoxin, lipopolysaccharide, causing circulatory inadequacy, tissue hypoperfusion, and this is manifested by hypotension, oliguria, adult respiratory distress syndrome. The underlying principle of investigation are to locate the site of infection and to identify the organism and to assess the severity of the disease. And these are the principle for the investigation. And first of all, the case of puerperal pyrexia is considered to be genital sepsis unless it is proven otherwise, as we have already said. And the investigation should be directed to find out any extragenital source of infection to account for the fever as well. And firstly, we have to take the history. History is the basic thing that we should do. The detailed antenatal, intranatal, and postnatal history of any high risk factor for the infection like anemia, prolonged rupture of membrane, or prolonged labor are to be taken. And the clinical examination includes thorough general physical and systemic examination. The abdominal and pelvic examination are done to note the involution of genital tract and locate the specific site of infection. The legs should be examined for thrombophlebitis or thrombosis. And the investigation include high vaginal swab or endocervical swab for culture in the aerobic and anaerobic media, and the sensitivity test to antibiotic. The clean catch midstream urine for the analysis and culture, including sensitivity test, should be done. The blood for total and differential WBC, differential leukocyte count, the total leukocyte count, and the hemoglobin estimation and the lactate measurement should be done. And low platelet count may indicate septicemia or DIC. And the thick blood film should be examined for malarial parasite. And the blood culture, if the fever is associated with chills and rigor, other specific investigation as per the clinical condition are needed. The serum urea, creatinine, and electrolyte may be done in the selected cases to have the baseline record. In the event that renal failure develops later in the course of disease, or laparotomy is needed. And the pelvic ultrasound is very helpful to detect any retained bit of conception within the uterus, to locate any abscess within the pelvis, to collect sample, pus or fluid from the pelvis, for culture and sensitivity, and for color flow Doppler study to detect venous thrombosis. Use of CT scan and MRI is needed, especially when the diagnosis is in doubt or there is pelvic venous thrombosis. And chest X-ray should be taken in cases with suspected pulmonary coast lesion, and also to detect lung pathology like collapse and atelectasis. The puerperal sepsis is a greatly preventable disease, and certain measures are to be carried out. And so the antenatal prophylaxis include improvement of the nutritional status to raise the hemoglobin level of the pregnant woman, and eradication of any septic focus like if the infection in the skin, throat, tonsil in the body. The intranatal prophylaxis include full surgical asepsis during delivery, screening for group B streptococcus in the high risk patient, and the prophylactic use of antibiotic is not recommended as a routine. And the prophylactic use of antibiotic at the time of cesarean section has significantly reduced the incidence of wound infection, endometritis, UTI, and other serious infection. And in the postpartum prophylaxis include the aseptic precaution for at least 1 week following delivery until the open wound in the uterus, perineum, and vagina are healed up, and too many visitors are restricted. Sterilized sanitary pads are used, and infected babies and mothers should be in isolated room. For the treatment, we have this. Firstly, we have to do general care, then the definitive treatment. The general care includes isolation of the patient is preferred, especially when the hemolytic streptococcus is obtained on culture, and adequate fluid and calorie are maintained by intravenous infusion. The anemia is corrected by oral iron, or if needed by any blood transfusion. Any indwelling catheter is used to relieve any uterine retention due to pelvic abscess, and it also helps to record urinary output. A chart is maintained by recording pulse, respiration, temperature, local discharge, and fluid intake and output. And the antibiotic is ideal antibiotic regimen should depend on culture and sensitivity report. The pending the report, empirical therapy with gentamicin 2 mg per kg IV loading dose followed by 1.5 mg per kg IV every 8 hours, and the clindamycin 900 mg intravenous every 8 hours should be started. The metronidazole 0.5 gram IV is given at 8 hours interval to control the anaerobic group. The treatment is continued until the infection is controlled for at least 7 to 10 days. The choice of antibiotic regimen, the severe sepsis, a combination of either piperacillin or tazobactam or carbapenem plus clindamycin has the broadest range of antimicrobial coverage. Women with MRSA infection should be treated with vancomycin or teicoplanin. And there now we have the surgical treatment. There is little role of major surgery in the treatment of puerperal sepsis. The perineal wound is managed are through the management of the episiotomy wound infection and dehiscence. We should give antibiotics, removal of suture and wound dressing, wound debridement under analgesia and anesthesia, repeated siege bath, wound dressing and debridement till healthy granulation tissue develop, secondary wound repair with non-absorbable suture, and removal of suture after 10 to 12 days. And the retained uterine product with the diameter of 3 cm or less may be disregarded and left alone. Otherwise, the surgical evacuation after antibiotic coverage for 24 hours should be done to avoid the risk of septicemia. The cases with septic pelvic thrombophlebitis are treated with IV heparin for 7 to 10 days. And the pelvic abscess should be drained by colpotomy under ultrasound guidance. The dehiscence of the episiotomy wound or abdominal wound following cesarean section is managed by scrubbing the wound twice daily. The debridement of all necrotic tissue and then closing the wound with secondary suture. The appropriate antimicrobial are used following culture and sensitivity. The laparotomy has got a limited indication. The maintenance of electrolyte balance by IV fluid along with appropriate antibiotic therapy usually controls the peritonitis. However, in unresponsive peritonitis, the laparotomy is indicated, and even if no palpable pathology is found, the drainage of pus may be effective. The hysterectomy is indicated in cases with rupture or perforation having multiple abscesses. Gangrenous uterus or gas gangrene infection, rupture tubo-ovarian abscess should be removed. Necrotizing fasciitis, it is rare but fatal complication of the wound infection, abdominal, perineal or vaginal, involving muscle and fascia. The risk factors are diabetes, obesity, hypertension, and the infection is caused by group A beta hemolytic streptococcus, and often it is polymicrobial. Tissue necrosis is a significant pathology. And the debridement treatment includes rehydration, wound scrubbing, debridement of all necrotic tissue, and the use of high dose broad spectrum antibiotic. Necrotic and necrotizing fascia. The indication for ICU care, ICU unit management are hypotension, oliguria, raised serum creatinine, raised serum lactate, thrombocytopenia, ARDS, and hypothermia. The management of bacteremic or septic shock include fluid and electrolyte balance to monitor central venous pressure, respiratory support to maintain arterial partial pressure of oxygen and partial pressure of carbon dioxide, circulatory support, dopamine or dobutamine, and infection control, intensive antibiotic therapy, surgical removal of septic foci, and the specific management as hemodialysis for renal failure. So the treatment of the complication are done, or bacteremic or septic shock. So that was all about puerperal sepsis, and in next video we will come up with a new topic on obstetrics and gynecology. Thank you. Till then, keep revising, and good luck for the your reading and MBBS. Thank you.